Or, John, I think we missed Kara.
Oh, oh, we got Kara. Kara, she just gave a very short,
Oh,
concise
well,
introduction.
we
Kara,
have
you
to
want to share
we
who
have to
you are
appreciate
again?
that.
That's okay. Thank you, Mark. Program coordinator here at Neomed, in case you missed it. Thank you.
Well, I guess I did. I must have been spacing out or something for a few minutes there. So it's nice to see everybody. Haven't seen Dan in a long time here. Dan's working in my hometown of Zanesville, and Alan works where I have a little vacation place up in Huron too. So it's really good to see everybody here. We're going to talk a little bit about trauma. Mark Hurst, I've been on this before. Um, I'm a psychiatrist, an addiction psychiatrist. Spent about half my career in state government and was the Department of Mental Health and Addiction Services and the Department of Health. Was medical director of both of those and was director for the Department of Mental Health for a while. Then I retired and decided it wasn't for me and went back to clinical work. And I worked at Mary Haven in Columbus, which is a opioid treatment program where I was the medical director. Enjoyed that a great deal. Then I retired again, and now I guess I'm semi-retired, although I think my wife would dispute the semi part of that. Most of the work I do now is with Center of Excellence for Substance Use Disorders at Case Western, where I'm the medical consultant. So that's kind of what I'm doing now. But what I'm doing this morning is we're going to talk a little bit about trauma and addiction. And for those of you who have heard me talk about it, this is reworked, so it's not exactly the same thing. There's nothing like it when somebody keeps recycling the same thing over and over and over again. So this is not totally recycled. Okay. Can we see that okay?
Yes.
Okay, John, keep me honest here in terms of time. And if questions come up in the chat, let's feel free to talk about them as we go through here. Okay. So, pregnant women and
Or wait, we still have it on you, so we're going to have you share screen.
No, we see
uh
the slides.
Oh, do you? I just
Yeah,
got a different format up. Okay.
all right. So everybody can see them okay then.
Yes.
yeah,
All
yeah.
right. Okay. Well, let's get going. So we're going to talk in general about trauma in people who have SUD, which we all know is quite common, and a little bit of emphasis on pregnant and postpartum women. Learning objectives. I don't think I'm going to spend a lot of time on this. Just looking at the prevalence of it, increase our comfort in dealing with it, and talk about some ways that we can address trauma. So let's start with the polling question here. My confidence in dealing with people who have experienced trauma in my practice is very high, high, average, low, or very low. So if you just want to pop some things in the chat there. Okay, yeah, so everybody feels fairly comfortable with it. Regardless of how much addiction medicine or psychiatry is involved in our practice, we see a lot of people with trauma. And we'll talk more about that as time goes on. So, why should we think about this? Why should we consider trauma, especially in people with substance use disorders? Well, a lot of people with substance use disorders have experienced childhood trauma, and a lot have also experienced trauma in adulthood. It's associated with a lot of problems, medical problems, psychological problems, poor social outcomes. And one of those outcomes of the childhood trauma is substance use disorders. We also need to be acutely aware of how the health system can re traumatize people. And when we re traumatize people within the health system, we drive them away from the health system. They don't get the results that they should. And that's not good for our society or for any individual. So addressing trauma at any point in life can really be helpful. It's never too late to do so. Some of you know Ted Winslow, who used to be the director of the Ohio Department of Health, and we were talking about trauma one day, and Ted said that he was in when he was in practice, a 90-year-old woman came in and was talking about things, and he said, I have to ask, were you abused as a child? And she said, yes, that's the first time anybody has ever asked me that. So never too late, and quite prevalent. So what's this thing we call trauma? Well, here's the SAMHSA definition. Hasn't changed. Guess it probably won't change since SAMHSA has been decertified and is being rolled into something else, I guess. But it's an event, a series of events, or a set of circumstances which is experienced by an individual, and the individual finds it as physically or emotionally harmful or threatening, and it has lasting adverse effects on their functioning in multiple domains. So it's really the three E's. There's an event, there's a negative experience from that event, and it has long-lasting effects. That's what SAMHSA considers trauma. Okay, now let's go to another polling question. To be considered a traumatic, to be considered traumatic, an event must be directly experienced by an individual. True, false, or I'm not sure. False, 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 false. Yeah, yeah. And that is false. Um, so it doesn't have to be directly experienced. It can certainly be secondarily experienced. So when we look at the different kinds of trauma, we're really looking at four basic things. One being the adverse childhood experiences, which occur during childhood, abuse, neglect, household dysfunction, those kind of things that can have long-lasting effects and do have long-lasting effects. Secondary trauma is where the person does not experience directly, but hears about it on a repeated basis and things like that, and basically develops all of the symptoms of PTSD or a traumatic response as if they would have experienced it themselves. So a person who has lost a relative in an auto accident or a homicide or something like that, they could experience secondary trauma and be affected by post-traumatic stress disorder as well. But let me pause just for a second. Trauma and a response to trauma is not always equal to PTSD, and we'll talk about that in a second. Vicarious trauma is something that is more likely something that we experience. So a person who's working in an emergency room or different places like that, which continue to see traumatic experience, trauma in others coming in again, again, and again, and again. And vicarious trauma doesn't really lead to symptoms like PTSD, but it does lead to things like cynicism and compassion fatigue and things like that, what we might call burnout, which of course is not a diagnostic term. That's a more generic kind of term. It's not, there's not a diagnosis with it. And then toxic stress, again, is something that we experience and the people that we work with can. So that's when a person has strong and frequent or prolonged adversity without adequate support. So it's not necessarily trauma that's directly witnessed or secondary trauma directly witnessed, but it's just being in a stressful environment for a long period of time. And we saw a lot of this with the COVID crisis, where people just kept coming in with COVID and COVID and COVID, and of course there were all the societal stresses that were superimposed on all of that, which contributed to it as well. So that's a little bit of burnout too, but we're not going to talk about that too much. So, what are some examples of traumatic experiences? Well, natural disasters, acts of violence, serious medical problems, particularly ICU hospitalizations, near-death experiences, losing a loved one, any kind of abuse, accidents, and the list can go on and on. But the common aspect of this is there's a theme of response, which is fear, shock, horror, and or helplessness. So it can be any of those kind of things. So it's really that recoiling after the event that happens. And sometimes that recoiling leads to a person just being incapacitated psychologically or even physically and just feeling really helpless with it. So how common is this? And this is derived from a lot of different sources. So you can't compare directly with all of this. But the bottom line from all of these references in all these different areas is that it's common, quite common. In the general US population, about 70% of people would self-identify as experiencing trauma, more in men than in women. Now, that said, although men are more likely to experience trauma, women are more likely to experience post-traumatic stress disorder following traumas. In men, it's accidents, physical assaults, and combat. In women, more commonly, sexual assault or child sexual abuse. Rates even higher in people who have substance use disorders, 90% in general, 86% in men, and around 100% in women. And I think most of us in clinical practice would agree with that. It's pretty rare to see a woman who has not experienced some kind of trauma in their life who has a substance use disorder. When we look in pregnant women, it's also high. So now we look at that 54% versus 70% in the population. That seems like well, that's a little bit low, isn't it? The difference is in these different studies, they have had different criteria and different thresholds for identifying trauma. So the threshold for identifying trauma in this particular study was much higher, and it was at 54%, which is still pretty high. And that was defined as trauma meeting the DSM-PTSD criteria. In pregnant women with substance abuse, again, we're looking at about 100% of people who are pregnant and have a substance use disorder having a traumatic experience. Physical abuse being the most common, emotional abuse being slightly behind that, and sexual assault and abuse certainly being quite escalated. So, what happens after a traumatic event? First, it's important to remember not everybody's going to develop a diagnosable psychiatric condition. Many people experience trauma. They feel upset about it for a while. They go on with their life and it doesn't cause a lot of dysfunction. In fact, that is more common rather than less common. The rates of it depend on a lot of different factors I'm going to talk about in just a second here. But, what kind of trauma is it? How severe is the trauma? How persistent is it? Is it repeated multiple times? And then what does the person who experiences the trauma bring to it? What kind of pre-existing experiences have they had? For significant trauma, about 10 to 20% of people will develop acute stress disorder, which basically has the symptoms of post-traumatic stress disorder. It's just immediately after the event or shortly after the event. And of those who have acute stress disorder, about half, three-quarters are going to develop PTSD. The use of alcohol and other substances to cope with trauma is very common, and that is something that should be discouraged. So that's something that really prophylactically or proactively we should look at if someone has experienced trauma and say, it may seem like having a drink or using some Xanax or something is going to be helpful. Let me assure you it's not. In fact, it could make things worse. So here's kind of what we're looking at. Traumatic event, if the person is more resilient, it is likely to resolve without lasting or disabling issues. If they're more vulnerable, a lot of different things can happen. Substance use disorders, pain syndromes, acute stress, PTSD, depression, lots of different outcomes can occur with this. Now, what I don't like about this slide, and I just couldn't figure out how to change it. This implies that either you're resilient or you're vulnerable. And we know that's not the case. We know that there is a scale between this. Some are extremely resilient, some of us are extremely vulnerable, but most of us are somewhere in the middle, and that may vary from time to time based upon where we are in life at any given point. So, if you experience trauma, what are the factors associated with the development of PTSD? Well, one is the severity of the trauma. More severe trauma, more likely that you're going to have a response to an acute stress and or post-traumatic stress disorder. And actually, traumatic events that are, what do we want to call them? Acts of man versus acts of God are more traumatic. So we have a tornado, we have a severe storm, we have an earthquake. That can be a severe trauma, but that seems to be less impactful than man's inhumanity to man. Things like war, crime, and things of that nature. Other factors, women are more likely to develop post-traumatic stress. People who are younger, who may well have not developed the skills of resiliency that those of us as adults have. Those who are less educated, if you have a prior mental health disorder in yourself or in your family, if you've had previous traumatic experiences, if you don't have a lot of social support, and if you have different life stressors. So if you're in a really stressful life circumstance and a traumatic event happens, it's more likely that you're going to have a negative response to that for the long term and develop psychiatric symptomatology with it. The previous traumatic experiences is kind of interesting. So this has been looked at in a lot of different settings, but one being in people in veterans who develop PTSD. Those who had childhood trauma are more likely to develop PTSD down the road. Now, there was a point that there was an effort to stop paying compensation for post-traumatic stress disorder because if a person developed this because they had a lot of previous trauma, well, why should this last traumatic event be something that a person is deserving of compensation for? I think a better way to look at that is, had they not experienced that last traumatic event, they may well not have developed PTSD. So yes, there is responsibility for us to address that appropriately. Okay, a little bit harder polling question this time. What's the preferred approach immediately following a traumatic event? And more than one answer is okay. Supportive care, prompt debriefing of the event, trauma-focused CBT, cognitive behavior therapy, psychological first aid, or pharmacotherapy. Which of these do you think would be the most likely? Okay. All right, we've got 4 and 1. Uh, Chris is saying 4. Sybil's saying 1 and 4, 1 and 4, possibly 5. 4, 1, 3, 4, 1, 2. Alan, we don't have 14 up here. I assume you mean 1, 4. Yeah, so those are good answers. So let's look at these one by one. So supportive care. Yeah, absolutely. That's the best place to start. Give folks education and information about the trauma, give them emotional support and practical kind of assistance. So, one of the most important things, natural disaster, make sure people have housing, people have food, people have water, people have the availability of those kind of things. That's really important, not only for their physical well-being, but because they have that human attachment that helps them through that period. Prompt debriefing of the event. No. That was really popular years ago, something called critical incident stress debriefing, but it does not prevent PTSD and it's potentially harmful. So debriefing doesn't seem to be helpful. Trauma-focused CBT, yes, absolutely. There's a good evidence base for this, including prolonged exposure, cognitive processing therapy, and EMDR. All those can be helpful. Psychological first aid, yes, absolutely, especially if there are low resources available. And if there's a mass trauma event, there may not be the ability to have a lot of individual attention to that. It may need to be briefer, and following the psychological first aid model can be helpful. Pharmacotherapy, no. In general, no. In the after acute trauma, no medications are demonstrated to be helpful, and specifically, benzodiazepines can worsen symptoms and increase the risk of PTSD. So, no benzos following an acute event. Okay, let's move on and talk about adverse childhood experiences a little bit. So, this story has been told many, many times. It was a collaboration between Kaiser Permanente and the CDC looking at the events, but really started with Kaiser Permanente. A fellow named Dr. Joe Folletti uh, recognized that trauma was impacting people in his practice, and I'm not going to go into it in great depth here. But he proposed to the administration of Kaiser Permanente that they screen everybody coming in for a physical examination for trauma. And they were skeptical of it, and but ultimately they agreed to do so with the caveat that somebody from his team needed to be available 24 hours a day, 7 days a week, in the event that asking someone about trauma led them to decompensate. So they, yeah, okay, we'll go ahead and do that. Uh, and over that entire period, um, there were 0 calls from people who had been triggered about asking about trauma. So that is a pretty good message that, yeah, it's okay to ask people about trauma, doing so in an empathetic way. 10 different categories were looked at: physical, emotional, and sexual abuse, physical neglect, emotional neglect, and household dysfunction in a lot of different ways, such as incarceration of a relative, substance use disorder, mother treated violently, family separation or divorce, and mental illness within the family. And so what they found is that as the ACE score increased, and ACE score means how many of these did you experience? How many of these different things did you experience? One, two, three, or more of those. So the ACEs are affiliated with a lot of different health problems. And as the ACE score increases, the risk for the health problems increases in a strong and graded fashion. So the more ACEs that a person has, the more likely it is that life doesn't turn out well for them from a medical perspective, from an educational perspective, from a social perspective. And when we look at substance use issues with that, we see it's really pretty common. Higher rates of alcoholism and alcohol abuse. I'm using the terminology that they used, not the modern DSM-5. Illicit drug use, smoking, and early initiation of smoking. So, that's pretty profound, really. Well, how common are these ACEs? Pretty darn common. So if you look at the general population, about 63% in total, 60% in men, 66% in women. People with substance use disorders, again, elevated, much more common in women than in men, somewhat more common in women than in men. But if you look at four ACEs, and that seems to be really the threshold where the rates of issues go up substantially. General population, about 17%. But when we look at people with substance use disorders, much higher. Again, much more likely to have adverse life outcomes as a result of these ACEs.
And Mark, we just posted a PDF of the ACEs 10 question instrument in the
Excellent.
chat.
Okay, thanks, John. And this is from the original study, which just showed more ACEs, more likelihood of having an alcohol use disorder. I guess I decided to switch to DSM-5 there, and more likely to have illicit drug use. And that would include increased likelihood to use drugs intravenously. Now, that said, a more recent study found that there was not that graded relationship, but any number of ACEs increased the risk of both AUD and illicit SUD. So, I don't know how much we need to parse this really. ACEs lead to multiple life issues, including substance use disorders. But what this study found is that the ACEs most associated with developing a substance use disorder or parental substance use disorder. And we can argue a lot about, well, is that the exposure of having an ACE with that, or is that a heritable aspect of substance use disorder, or both? I think most of us would say, yeah, it's probably a combination. Physical abuse and sexual abuse. So those were the most common associated with it. Well, let's toss pregnant women in here. So this is what the first columns are what we talked about. But in pregnant women, about 71% had ACEs. Again, not the same methodology, but compares fairly well to the general population. And more than four ACEs also does. But if you add substance use disorders on top of pregnancy, the rates increase markedly. So 85% having at least one ACE, about half having more than four ACEs. So lots of increased propensity to have problems. All forms of abuse are associated with increased substance use during pregnancy, not necessarily substance dependence, but increased substance use, whether it's emotional, sexual, physical, all those increase the rate. Clear relationship between the two. And in pregnant women, most common ACEs get emotional, physical, sexual abuse, SUD, separation, and divorce. So when we look at the ACEs again in the strong and graded fashion, and we look at things that that have to do with pregnancy, increased rates of fetal death, increased risk of intimate partner violence, which is something we always need to address in pregnant women, and particularly those with substance use disorders. Multiple sexual partners, sexually transmitted diseases, HIV, increased risk of adolescent pregnancy, early initiation of sexual activity, and unintended pregnancies. So the ACEs are associated with a lot of these things. We've had discussions before about, well, is it cause and effect? The association is pretty strong. Now, to definitively state, yes, it's cause and effect, I don't know that we can do that, but the association is quite strong. What other things do we need to look at? When you have the triad, substance use disorder, trauma, and mental illness, the risk of adverse outcomes increases fairly markedly as compared to only one. So, and it's in more than an additive kind of way. There's an increased risk of multiple system involvement. So involvement with criminal justice, with child services, mental health system, substance use system, lots of different systems. The risk of ongoing and recurrent trauma should not be neglected. Certainly people who are substance using and pregnant frequently are in abusive relationships. We need to ask about that and deal with that. Social isolation and rejection. Substance use disorders are socially isolating and lead to rejection from the rest of society. Being pregnant can do so even more. And one of the ironic things, I would really say the saddest things, is that even in people who strongly believe that substance use disorders are biomedical illnesses, pregnant women with substance use disorders are not treated by anybody, including those folks, in the same kind of way. So although people who aren't pregnant, we may say, gosh, this is all a consequence of your substance use. We need to deal with that. It's not uncommon to hear even people in the substance use disorder field saying, how can this person use substances when they're pregnant? Well, those of us in the field know that does happen. And if we reject somebody, they're less likely to follow up in treatment. And not only does it lead to them not doing well, it leads to their child not doing well. And that's not good for any of us. So that triple stigma has something to do with it. Concerns over treatment seeking. What's going to happen if I seek treatment? If I seek treatment if I go to OB treatment, am I going to be turned over to the police? Is my child going to be taken away from me? Those are all legitimate concerns that folks have and need to be addressed. And of course, we can't forget the risk of overdose. And we need to prepare for that. We need to be sure that people have resources to prevent that and to reverse that if necessary. What's the mechanism that it happens? Well, many times, I don't know if this happened. Okay, well, many times folks have kind of the social context for things to go poorly. Poverty, housing issues, things of that. And there may be historical trauma within their community. When we layer on adverse childhood experiences, that can lead to disrupted neurodevelopment, impairment in different areas, and in order to cope, adoption of health risk behavior. And so that is kind of the pyramid of how that happens. And of course, we have to show a picture of the brain here. This talks about the brain reward system and trauma. But I'm going to talk a little bit differently. Let's look at the hippocampus and let's look at the pituitary because trauma, and particularly chronic trauma, leads to disruption in the HPA axis. So there's often high cortisolemia with that and all the negative effects that are associated with it. And that leads to some of the illnesses that are associated with trauma, as well as a lot of other bad outcomes. Okay, so how do we deal with it? Well, we can look at the 4 R's. Realize that that trauma is very common and understand how a person can recover from that. Recognize the signs and symptoms of trauma in the people we're treating, in their families, in our own staff and in others involved with the system and respond by putting our knowledge together about this in terms of clinical practices, but also into policies and procedures. So we have an environment where individuals who have experienced trauma can be successful. And specifically, we need to resist re-traumatization, which we do all too common. And I'd add a fifth with that. Let's add respect. That if we are respectful to one another and respectful to those who are in treatment with us and to our staff, uh, I think that we end up a lot better. And that really encompasses all of these things too. What are the guiding principles? This is from CDC. I'm not going to go to them in depth, but to have a trauma-informed environment where a person is welcomed, where a person is not experiencing re-traumatization, these are kind of the things that are that are part of it. Making sure that the environment is safe and the person feels safe. Making sure that they understand that we are going to be trustworthy and transparency, understanding that our actions speak much more loudly than our words do with that, having peer support available, having collaboration and mutuality. So person has input into their own healthcare decisions and doesn't feel like things are being imposed upon them, which we can obviously see is an issue for people with trauma who have had things involuntarily imposed upon them and have created multiple life issues. Empowerment and voice and choice. So making sure that people know you do have a role in this, you have the most important role in it, and considering the background, the cultural issues, historical issues for the individual and the culture that they come from, and with gender issues. So trauma-informed care is the foundation for helping people with traumatic histories, but it's not treatment for PTSD. So it's really the foundation. It's where we always need to start, but that in and of itself doesn't treat PTSD. So what kind of things can we do? One is to have universal precautions. So assume that everybody who comes into our care has experienced trauma, even if we don't know their personal history. So if we set up that trauma-informed care environment, no one is going to be harmed by that, and many people are going to be helped by it. Create a welcoming environment with a feeling of safety. So, look at the physical space. Is it something that's welcoming? Is it a place that you would want to go? Is it a place that you would want to come back to? Making sure that our tone of voice is something which is reassuring, calming, and voices helpfulness. Eliminate kinds of things that could be anxiety provoking. And that really depends upon what kind of population you're treating. Some of the ground rules with it. Be really aware of personal space. So if you're somebody who likes to touch patients or to hug patients or things like that, rethink that. Because that can have different meaning for different kinds of individuals. I think that that's generally considered not appropriate in the medical field in this day and age, but some folks still do it. And, I would advise against it. Taking an authoritative approach. Again, we don't want to have the person feel like we're imposing things upon them. We want them to be involved with it. Standing over the person, so kind of looking down on them, not a good thing. Blocking their exit. So getting between the individual and the door, they need to feel that they have a way out. Even if it's a non-threatening kind of thing, make sure that that they have a way that they can take care of their needs if need be. And support their voice and choice. The expression, nothing about me without me. So don't make the decisions for the patient. Make sure that they're the most important part of it. Real simple ways of dealing with it. Screen for the trauma history. Ask them about any positives from the screening questions. How has that affected your life? Listen to what they have to say. Empathize with them. So a simple comment like, that must have been difficult for you. You must have great strength within you to get through that. Things that are going to be helpful from that perspective. You don't need to know every detail about the trauma that people experienced, but asking about it and being empathetic is impactful. Thank them for sharing the information with you and accept them for who they are and where they are. So ask them about it, listen to what they have to say, and accept them where they are. And if we just do that, there's about a 35% reduction in outpatient visits from baseline. That's pretty substantial, and 11% reduction in emergency department visits.
Mark, Dr. Block shared experience that some people are triggered by being approached from behind, like if
Yep.
a physician is trying to listen to their lungs, and that was something he learned to ask before doing so.
Yep. I think it's all, Dan, that's a great point. I think it's always good to ask permission. And if you're going through a physical exam, yeah, we know what we go through. I mean, you say, I'm going to be listening to your lungs now. I'm going to be coming behind you to do that. If they say, no, 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 don't do that, a good point. So, yeah, well stated, Dan.
And Mark, we have about 16 minutes left, a little less if we want time for dialogue.
I only have about 18 minutes worth of slides left, John, so we're in good shape. No, we're coming down to the end here. Choice, referrals for people who have trauma history. So choice is really important. Keeping in mind, everybody benefits from a trauma-informed environment and provider. No one's harmed by that. A lot of people don't desire trauma treatment, specific trauma treatment, and many don't require that. Again, trauma-informed care, not the same as treatment for PTSD. Not all people who have experienced trauma have PTSD. But if an outside referral is necessary, keep in mind that that can lead to feelings of rejection. It's hard for people who have trauma to trust. And if they say, well, this is beyond me, you need to go see John Ellis for therapy here, you need to be sure that that is presented in a way where the person does not feel rejected and that they know you're going to continue to be with them. So, I'm going to continue to be your doctor, but I think you need a little more expertise in this particular area. So I'm going to refer you to John. I want to see you back after that, and let's talk about how things are going with it, so we can coordinate care for the best of you, for your best outcome. So again, making sure that they don't feel rejected with it. They've experienced the ultimate in rejection in the trauma that they have had. If you do make that referral, coordinate the care with them. Talking to a person in advance is always helpful, and refer to providers who provide evidence-based treatment. So the kind of things that we talked about before. Not all people who claim to be experts in trauma are providing evidence-based treatment. And some of those methods that folks deal with it in fact can be harmful to the individual. So we want to be sure that they're getting good treatment that's evidence-based with a higher likelihood of a good outcome. First things first, everybody who's experiencing SUD and trauma, first thing is to establish stability. Treat life-threatening things first: medical compromise, suicidality, risk of lethal overdose, risk of experiencing violence, homelessness, nutrition, those basic kinds of things. And the usual kind of approaches that are used: pharmacotherapy, counseling, social interventions, whatever is necessary. And always trauma informed. This is something I'm not going to spend a lot of time on. This is a study from JAMA from about 10 years or so ago, which looked at relapse time in individuals who had not experienced childhood maltreatment. The bottom line is that people who had experienced childhood maltreatment relapsed sooner than individuals who had not, and relapsed deeper. So again, we need to be sure that we're looking at that, dealing with that, and prepared for it.
And Mark, there's another study posted from 2019 that they used ACEs as a assessment tool in treatment, and determined that for every 1 point, and this is opiate use disordered individuals in treatment, for every 1 point they were positive on the ACEs study, increased their relapse potential by 17%.
Wow. Yeah, I had not seen that study. Thanks for putting that in there. The other part that they looked at this was actually brain parenchymal volume here. And as you might expect, with the high cortisolemia and everything, there is more likely to be an element of atrophy in individuals who have experienced trauma. So when we talk about people not getting it, well, sometimes they don't get it because they're not having the cognitive function yet to do that. And we need to consider that in how we do treatment. How about helping pregnant women? Not going to go through all this, but we need to keep in mind that pregnant women with substance use disorders, all pregnant women, but particularly those with substance use disorders, have a lot of things they need to deal with. The OB care, mental health care, housing, transportation, healthcare coverage, legal issues sometimes. There's a lot to deal with there. So when we look at dealing with trauma, we need to consider it in the context of the whole individual and what they have to deal with. During the pregnancy itself may not be the best time to pursue intensive trauma treatment. Trauma-informed care, absolutely. Acknowledging it, absolutely. Uh, but in collaborating with the patient, we need to keep in mind lots of stuff they have to deal with all of this. So, same kind of things we need to be sure of. Treat life-threatening conditions first, life-threatening to the mother, life-threatening to the baby. Make sure they get good OB care early on. Suicidality, not uncommon. The risk of lethal overdose, make sure they have naloxone that's available. Risk of experiencing violence, which is certainly out there, homelessness and nutrition. Again, use all the interventions that we usually do, make sure they're appropriate to pregnancy. So, what kind of things do we definitely need to do? Address stigma, all aspects, mental illness, substance use, trauma, pregnancy, and the specific stigma that presents all of those things together. Don't re-traumatize. Never tolerate punitive attitudes in your staff, in yourself, in anybody. Don't withdraw them from opioids. I think that's been dealt with a lot in this echo. That's really dangerous for the baby. Do treat them with medications for SUD and if needed for mental illness that have a good benefit risk ratio. Buprenorphine, methadone, absolutely. Do ask about housing, nutrition, and safety, and ask about that every visit because housing in substance using women, and particularly those with trauma, tends to be fluid. They may be stably housed at one point and you see them the next month and they aren't. So address that every visit. That is an important thing to make sure that they have stable housing and good nutrition. And be kind, be welcoming, and respectful, of course. Why do we do this? Well, with trauma-informed care, things turn out better. They turn out better for our clients. They turn out better for us. And be sure to take care of yourself because the work we do is hard. Work on making your practice site trauma informed. And it's not a yes or no. It's something that takes a while with it. It should be an organizational priority, or sometimes the staff starts it, which is even better. And it benefits everybody. Accept all of our patients where they are because they can get better no matter how ill they appear to be. And also accept ourselves where we are because we can get better too. None of us are perfect. We learn all the time and we can get better all the time. Help everybody we treat as best we can, but don't try to be their savior. Don't tie up all of our self-esteem in our patients getting better. Keep in mind, don't need to extract all the specific elements. Ask for help if you need it. Ask for help clinically if you need help with a given patient. Ask for help of yourself if you need it. And keep in mind, preventative care applies to you as much as to those you're treating. Take home points. High rates of trauma in people with SUD. Almost all women with SUDs have trauma, also in pregnant women. And everybody who experiences maltreatment and household dysfunction have an increased risk of a lot of problems in life. Pregnant women, more likely to have complicated pregnancies and require a more comprehensive approach. Screening for trauma and nurturing that environment does make a difference. Treatment works, and you can do a lot of it. Dealing with trauma is a journey, not an event. So it takes a long time to deal with this, perhaps a lifetime, and take care of yourself because your family and your patients deserve you at your best. And I think we have a few minutes to talk.
So let's open it up. Does anybody have any comments for Dr. Hurst?